Your differential diagnosis is basically between chronic phenomena and superimposed epiphenomena. That is, does this patient have a previous history of cognitive problems or not? And if they do, is this a diabetic problem? Is this a uremic problem? Is this a Alzheimer problem? Is it a trauma problem? And you really have to get it right. Second thing I'm going to do is compare and contrast clinical presentation of frontotemporal dementia versus early Alzheimer's versus Lewy body dementia. And the single most important thing I'm going to say today is you need to look for frontotemporal dementia in everybody. And one of the reasons is because Medicare will pay for a fluorine 18-deoxyglucose scan of the brain for the differential diagnosis of frontotemporal versus Alzheimer's. So how do you bring frontotemporal into your differential? You talk to the patient's significant other and you say, has this person been socially inappropriate in the last year? And you go ahead and you document everything that's said. The critical thing here is that frontotemporal dementia has nothing to do with acetylcholine. If somebody's got frontotemporal dementia and you put them on Aricept or a Exelon patch, they get 100% of the cost, 100% of the risk of asthma, 100% of gastric upset, and zero possible benefit. Not a good deal. Other thing, Lewy body dementia. Lewy body dementia is a loaded gun. Lewy body dementia, often called the Lewy body variant of Alzheimer's, is a significant problem. The patients will talk about visual hallucinations, problems with seeing things that aren't there, and visual hallucinations. And in today's society, we tend to reach for a neuroleptic. And the only problem with that is that patients who've really got Lewy body dementia have exquisite sensitivity to neuroleptics. And there's two levels of sensitivity. One level of sensitivity is you give them 1/10 of the lowest recommended dose, and they're in the ICU for 3 days. Malignant neuroleptic syndrome. The other version is you've kind of got them managed on a low dose, and you switched them to a medium dose, and then they're in the ICU for 3 days. So you need to figure out whether they've got Lewy body dementia, and you need to approach neuroleptics with exquisite caution. Now, comorbidities. The comorbidities are the main reason I'm talking to you. Vascular dementia. The fact is that each and every one of you can drop the prevalence of dementia in your practice by about 40% using what you know today, because everything that's good for the brain is good for the heart, and everything that's good for the heart is good for the brain, and about 40% of dementias that wind up signed out as Alzheimer's actually have a very significant vascular component from inadequately controlled hypertension. from microvascular disease, from endothelial dysfunction, all of which you know how to handle much more aggressively than the average clinician. Now, precise diagnosis relates to therapeutic intervention choice and to the risks. So, acute problems: falls, alcohol, drugs, depression. Falls are the big one. For patients over 65, 1 out of 3 falls each year. For the patients who fall, 40% mention it to their physician. 60% don't. Why? Maybe they're forgetful. Maybe they're afraid you'll send them to a nursing home and they'll lose their autonomy. But if you don't ask, they won't tell. And falls can very readily cause somebody who just had mild cognitive impairment to really deteriorate in a major way. And so what you have is a chronic morbidity and a superimposed acute event. This will respond usually to rehabilitation. It doesn't mean they need to be assigned to a nursing home where they'll become depressed and never come out. Alcohol is certainly a common problem in this group of people. It's a common cause of falls. It's a common cause of depression. Drugs, there are lots of people who don't tell their physician about the Benadryl habit they have. And yes, it helps them get to sleep, but they don't quite wake up very well in the morning. And depression is always to be looked for. Okay, so you're a confused patient, you've looked for all of these acute things, and you say, gee, what's the time course? Is this an acute onset? Is it potentially reversible? Chronic? Interestingly enough, Alzheimer's, frontotemporal, Lewy body, vascular dementia. If you talk to pathologists, they'll find some bit of several different pathologies, and they'll sign it out as the one that's dominant. So yes, about 85% will be signed out as Alzheimer's disease, and maybe 10% as frontotemporal dementia, and depending upon whether they call Lewy body dementia separate from Alzheimer's or a variant of Alzheimer's, you've got at least another 5%. Vascular dementia is vastly undercalled. It's a very, very, very significant component of dementia. It's largely preventable, and it's about 40% of the cases have a very significant vascular component. And if somebody has mild Alzheimer's and they develop atrial fib and go ahead and have a couple of little strokes, they fall apart.